welcome back to the deep dive.
Yeah.
Today, we're doing something a little bit different.
Yeah, we are. We're shifting gears.
Exactly. This isn't just about exploring a topic for curiosity's sake. Today, we're stepping into the exam hall.
We are, and it's a big one.
I'm looking at a huge stack of books on the desk here. We've got Miller's Anesthesia,
Yeah.
Stolting's, Morgan and McKyle, O's Intensive Care.
The whole library, basically.
Right. And our mission today is incredibly specific. We are going to construct, piece by piece, the perfect high-yield model answer for a topic that is an absolute favorite of examiners.
Acute pain management.
Acute pain management.
And it is a favorite for a very good reason. If you're an MD anesthesiology student, especially if you're prepping for the Gujarat University exams or the DNB, you know this is coming.
It feels inevitable.
It is, because it tests everything. It tests your basic sciences, your pharmacology, your clinical skills, your decision-making. Frankly, if you can't manage acute pain, you can't be an anesthesiologist.
Okay, so for the next 40 minutes or so, I want you to imagine I am the resident, the exam paper's right here, or maybe I'm standing at the Viva table sweating a little.
A very familiar feeling.
The question is, acute pain management principles, modalities, and clinical application. Where do we even begin?
You begin with a solid framework. In an exam, you have to show the examiner you're not just a technician who knows drug doses, you're a clinician. You understand the why.
With the fundamentals.
The fundamentals. And that always starts with the definition. And for an exam, you can't paraphrase. You must quote the IASP definition, the International Association for the Study of Pain, verbatim.
Okay, that's a high-yield point right there. Don't ad-lib the definition. I have it here from Miller. Let me read it out. And for everyone listening, this is one to commit to memory.
Please do.
An unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage.
Perfect. Now, if you're in a Viva, you don't just stop there. You don't just recite it like a robot. You unpack it a little.
The word emotional jumps out.
Exactly. Highlight that word. Pain is subjective. It is not just a nerve impulse. It's how the patient feels about that impulse. It's an experience.
This protects you from that trap of thinking, oh, it was only a small surgery. They shouldn't be in this much pain.
Precisely. If the patient says they are hurting, then by definition they are in pain. End of story. And notice the phrase potential tissue damage. Pain can exist without an obvious injury.
That really sets the stage. But why is it such a big deal for the examiners? I mean, beyond the obvious humanitarian reason that we don't want people to suffer, what are the hard medical consequences of getting this wrong?
This is where you got your first big chunk of marks in the introduction. You have to list the physiological consequences of inadequately treated pain. It is a multi-system catastrophe.
Okay, let's break that down. System by system, where do we start?
Let's start with the heart, cardiovascular system. Pain triggers a massive sympathetic nervous system response.
The fight or flight response.
Right, so you get tachycardia, hypertension. What does that do? It cranks up myocardial oxygen demand. Now, if you have a patient with pre-existing coronary artery disease, that pain can be the very thing that pushes them into ischemia or a full-blown MI.
So treating pain is, in a very real way, a form of cardiac protection.
100%. You are actively protecting the heart. Now, what about the respiratory system? This is huge, especially after abdominal or thoracic surgery.
If it hurts to breathe, you don't breathe.
Exactly. The patient splints. They take these tiny, shallow breaths. Their functional residual capacity, the FRC, plummets.
And that leads to atelectasis. The little air sacs collapse.
They collapse, secretions start pooling in there, and suddenly you've got a patient with hospital-acquired pneumonia, all because their pain wasn't managed.
So we're preventing pneumonia and heart attacks. This is not just about comfort.
Not at all. And don't stop there. You have to mention the metabolic stress response. Pain puts the body into a catabolic state.
Breaking things down.
Yes. Hyperglycemia, protein breakdown, lipolysis, this impairs wound healing. It messes with the immune system. And then there's coagulation.
DVT and PE.
The stress response makes the blood hypercoagulable. You combine that with a patient who is refusing to get out of bed and move because they're in agony, and you've created the perfect storm for a deep vein thrombosis and a potentially fatal pulmonary embolism.
And what about the psychological side of it?
That's the final piece of the puzzle. Anxiety, sleep deprivation, and the big one that Miller really emphasizes, the risk of the pain becoming chronic.
CPSP, chronic post-surgical pain.
Yes. The single biggest predictor for developing chronic pain after surgery is the severity of the acute pain in the first few days. By treating the acute phase aggressively and effectively, you are literally preventing a lifelong debilitating disease.
Okay, that's a powerful introduction. We've defined it, we've explained the high stakes. Now, let's think about the exam format. You see this as a full 20-mark long answer, right?
Most often, yes. But you'll also see it broken down into short notes.
Like, discuss multimodal analgesia, or write a short note on PCA.
Correct. So if it's the big 20 marker, you need that rigid structure. Definition, a bit of physiology, assessment, then your management pillars, pharmacology, regional techniques, non-pharma, and then organization, like the acute pain service, and finally, complications. Miss one of those, you lose marks.
Okay, let's hit that second pillar then, the physiology. We don't want to write a whole textbook chapter, but we need to show we understand the mechanism.
Exactly. You keep it simple and clinically relevant. Just trace the 4 main processes, the pain pathway.
Step 1 is transduction.
Right. This happens out in the periphery at the site of the injury. The noxious stimulus, the surgeon's scalpel, a burn, gets converted into an electrical signal and action potential. This involves nociceptors and a whole soup of inflammatory mediators. Prostaglandins, bradykinin.
And this is where drugs like NSAIDs and local anesthetics have their first shot at it.
Precisely. NSAIDs reduce the prostaglandins that are sensitizing those nerve endings. A simple wound infiltration with local anesthetic blocks transduction directly. You're putting the fire out before it really starts.
Okay, so after transduction, we have transmission.
The signal now has to travel up the nerve to the spinal cord. And you should mention the 2 main fiber types. You have the A-delta fibers. They're fast, they're myelinated, they carry that initial sharp, ouch, pain.
First pain.
The first pain. And then you have the C fibers. They're slow, unmyelinated. They carry that dull, throbbing, aching pain that sets in later. The second pain.
And they're all heading for the spinal cord.
Specifically the dorsal horn of the spinal cord. And this is where the third and arguably most interesting step happens. Modulation.
This is the gate control theory.
This is the gate. The signal doesn't just pass through like a message on a telephone wire. It gets modified. It can be amplified, a process called wind-up or central sensitization, or it can be dampened.
How is it dampened?
By descending inhibitory pathways coming down from the brain. These pathways release neurotransmitters like serotonin and norepinephrine that act like a brake on the pain signal.
Which is why, rubbing your shin after you bump it actually helps. You're sending other signals up to try and close that gate.
That's the perfect analogy. And this is also where opioids and alpha-2 agonists do their powerful work at the spinal level. Finally, the 4th step is perception.
The brain.
The signal ascends to the thalamus, the limbic system, the somatosensory cortex, and only then does the patient have the conscious experience of, I am in pain.
Both Miller and Stolting make a really big deal about distinguishing acute from chronic pain. And it's not just a matter of time.
No, it's about function. This is a key distinction for the exam. Acute pain is a symptom. It's biological, it's protective, it's your body telling you, move your hand from that hot stove or don't walk on that broken leg.
It serves a purpose.
A vital purpose. And it generally resolves as the tissues heal. Chronic pain, on the other hand, usually defined as pain lasting more than 3 months or beyond the normal healing time, has no protective function. It's maladaptive. The nervous system itself has changed. It's undergone neuroplasticity. To put it simply, acute pain is a symptom. Chronic pain is a disease in its own right.
Okay, that's crystal clear. We have the basics down. Now, let's get to the core of the answer. The principles of management. If I had to use one single buzzword to make the examiner sit up and take notice, what is it?
Multimodal analgesia. If you write an answer about pain management and that phrase is not in the very first paragraph of your management section, you are in serious trouble.
So let's really break that down. What does multimodal analgesia actually mean in practice on the ward?
It means we stop searching for a single magic bullet drug. Instead of giving a massive dose of morphine that stops the pain but also stops the patient from breathing.
Use a combination of things.
Exactly. You use smaller doses of different drugs that act on different parts of that pain pathway we just discussed. So you might use an NSAID to target transduction.
A regional block to stop transmission.
And a small dose of an opioid to modulate perception.
So it's like a 1 + 1 = 3 situation. A synergy.
That's the perfect way to describe it. It's synergistic. You get better quality pain relief while drastically reducing the side effects of any single drug class. And the key phrase to use in your exam paper is opioid sparing. You want to reduce the total opioid burden to minimize respiratory depression, nausea, vomiting, and ILS.
What about the other principles? What comes after multimodal?
Individualized care. It sounds obvious, but it's crucial. You treat the patient, not the procedure. A young, fit, 25-year-old having a knee reconstruction needs a totally different pain plan than an 80-year-old frail patient with kidney disease having the same surgery.
You have to titrate to effect.
You titrate to effect. And you should also mention the concept of preventative or preemptive analgesia. The idea of getting in there before the incision is even made to block those pain pathways and prevent the nervous system from getting wound up in the first place.
Okay, that makes sense. Moving on to assessment. This seems so simple on the surface. Just ask the patient if it hurts. But I get the feeling there are some major Viva traps here.
Oh, there are. The biggest trap is thinking that you, the doctor, can judge how much pain your patient is in just by looking at them.
The gold standard then is self-report.
Always. Pain is whatever the experiencing person says it is, existing whenever they say it does. You cannot look at a patient and say, "You don't look like you're in pain." That's a failing answer.
So for the exam, we need to list the scoring systems.
You absolutely must. First, the visual analog scale, the VAS. It's a 10-centimeter line. One end says no pain, the other says worst possible pain. The patient makes a mark on the line. It's great for research and for tracking changes in a single patient over time.
But maybe not the most practical for a busy ward.
Correct. For the ward, the NRS, or numerical rating scale, is king. On a scale of 0 to 10, with 0 being no pain and 10 being the worst pain imaginable, what is your score right now?
Simple, quick, effective.
Very. And then there's the VRS, the verbal rating scale, just mild, moderate, or severe. Simple, but still validated.
Okay, but what about the patient who can't communicate? The intubated patient in the ICU, the confused elderly patient, the pre-verbal child?
Excellent question. You can't just guess. You have to use validated behavioral scales. For adults in the ICU, you should mention the BPS, the Behavioral Pain Scale, or the CPOT, the Critical Care Pain Observation Tool.
And what are they looking at?
They score things like facial expression. Is the patient grimacing? Muscle tension. Are they rigid or tense? And for ventilated patients, compliance with the ventilator. If a patient is constantly fighting the vent, coughing, setting off alarms, there's a good chance they're in pain.
Okay, here's a trap I remember reading about in O's intensive care. Can we rely on vital signs? If the patient's heart rate is 70 and their blood pressure is normal, does that mean they're pain-free?
Absolutely not, and that is a classic Viva trap. An examiner will ask you that directly. While severe acute pain can cause tachycardia and hypertension, the absence of those signs means nothing.
Why not?
Well, the body can adapt. Or the patient might be on a beta blocker that's masking the tachycardia. Never, ever say in an exam the patient isn't in pain because his pulse is normal. The correct answer is always that self-report is the gold standard, and in its absence, we use validated behavioral scales.
Got it. Trust the patient or the scale, not the monitor.
Precisely.
Okay, let's get into the toolbox, the pharmacological methods. We can think of this as that multimodal pyramid. Let's start at the base. Non-opioids.
This is your foundation, your baseline therapy. And it starts with paracetamol or acetaminophen.
How does it actually work? It's not really an anti-inflammatory.
Its mechanism is still a bit debated, but we think it works centrally. Probably by inhibiting a specific COX variant in the brain and by modulating those descending serotonergic inhibitory pathways we talked about. It's safe, it's effective, and it is definitely opioid-sparing.
And for the exam, is there anything special to mention about it?
Yes. Mention the 5E formulation. Intravenous paracetamol gives you very predictable, reliable plasma concentrations compared to oral or rectal routes, which is incredibly useful in that immediate post-op period when the gut might not be working properly yet.
Makes sense. Okay, what about the other big player at the base of the pyramid? NSAIDs.
The nonsteroidal anti-inflammatory drugs. Ketorolac, diclofenac, ibuprofen. These work peripherally. They inhibit the cyclooxygenase, or COX, enzymes, which stops the production of prostaglandins right at the site of injury.
And they are fantastic for what kind of pain?
Somatic pain, pain from skin, muscle, bone. They are brilliant for orthopedic pain, for example. But, and this is a huge but, for the exam, you must list the cautions and contraindications.
The famous 3 risks.
The big 3. First, gastrointestinal bleeding, because they inhibit the protective prostaglandins in the stomach lining. Second, renal dysfunction, for the same reason in the kidneys. And third, platelet inhibition, which increases bleeding risk.
And there's a more subtle one, right? Something from Morgan and McHale about bone healing.
Yes, that's a sophisticated point to make. There is a controversy and some evidence, mostly from animal studies, that NSAIDs might impair bone healing and fusion, so you'd be cautious using them long-term after a major spinal fusion, for example. Mentioning that shows you've read beyond the headlines.
Okay, we've built our base. Now let's climb the pyramid to the heavy hitters. Opioids.
These are still the mainstay for moderate to severe acute pain. They work primarily on mu-opioid receptors in the brain and spinal cord to block pain transmission and, very importantly, to change the emotional response to pain. They make you care less about it.
We're talking morphine, fentanyl,
The
hydromorphone.
classic agents. And you need to talk about routes of administration. The preferred route for titration is IV in small, frequent boluses. You should actively discourage intramuscular injections in your answer. They're painful, and absorption is erratic and unreliable.
Can we differentiate them a little in Aviva? If I'm asked why I might choose fentanyl over morphine for a particular patient, what should I say?
That's a great clinical question. It comes down to pharmacology. Morphine is the classic, but it has active metabolites, particularly morphine 6-glucuronide, which are cleared by the kidneys.
Ah, so in a patient with renal failure.
Exactly. Those metabolites can accumulate and cause prolonged, dangerous respiratory depression. So for a patient with kidney disease, fentanyl is a much safer choice because it has no active metabolites.
And fentanyl is faster on, faster off.
Right. It's much more lipid-soluble, so it crosses the blood-brain barrier very quickly for a rapid onset, but then it redistributes out into fat tissue, so its duration of action from a single dose is shorter.
And the side effects. The list is long.
It is, and you have to know it cold. Respiratory depression is the one we fear the most, but postoperative nausea and vomiting, PONV, is the one patients complain about the most. Then you have pruritus, which is that awful itching, especially with spinal opioids, urinary retention, and ileus, the slowing down of the gut. They're fantastic analgesics, but they come at a price.
Okay, let's move to that other category. The adjuvant analgesics. These seem to be a really hot topic now.
They are, because they're a key part of that multimodal opioid-sparing strategy. And the big one you have to talk about is ketamine.
But in low sub-anesthetic doses.
Crucially, yes. We're talking about infusion rates of maybe 1 to 2 micrograms per kilo per minute. It works as an NMDA receptor antagonist.
And why is blocking the NMDA receptor so important for pain?
Because that NMDA receptor is the gateway to central sensitization. It's the key molecular mechanism behind that wind-up phenomenon in the spinal cord. By blocking it, low-dose ketamine can prevent the nervous system from amplifying the pain signal. It's especially useful for opioid-tolerant patients or for intensely painful surgeries.
What about the gabapentinoids?
Pregabalin and gabapentin, you should mention them. They work by binding to a specific subunit on calcium channels in the nerves, which reduces neuronal excitability. They are particularly good if you suspect a neuropathic component to the pain, that burning, shooting, electric shock type pain.
And the alpha-2 agonists?
Clonidine and dexmedetomidine, they have a role too. They work in the dorsal horn to inhibit pain signals, and they provide a bit of sedation and anxiolysis, which can be very helpful. They're great adjuvants to add to regional blocks, for example.
Okay, that brings us perfectly to what is arguably the anesthesiologist's most powerful weapon in this fight: regional anesthesia.
This is an absolute core topic for the exam. You have to show you're an expert here. And you start with the neuraxial techniques. The epidural catheter is still the undisputed gold standard for pain relief after major open abdominal or thoracic surgery.
So why is an epidural so much better than just, say, a PCA pump with IV morphine?
Because it provides superior analgesia, especially dynamic pain, the pain on coughing and moving. And by doing that, it blunts the systemic stress response far better than any systemic drug can. Miller lists the benefits very clearly. It reduces pulmonary complications because the patient can cough and deep breathe without agony. It facilitates a much earlier return of GI functionless ileus because you're not flooding the system with opioids. And it even decreases the risk of DVT and PE because the patient gets moving sooner.
I saw a phrase in Miller that seems important: catheter-incision congruency. What does that mean?
It's a critical concept. It means you have to put the catheter in the right place. If the surgeon is making a big thoracic incision at the T6 level and you place a lumbar epidural down at L3, you're not going to get effective analgesia unless you use a huge volume of drug.
And that would cause problems.
Massive problems. You'd get a dense motor block of the legs, the patient can't move, and you'd get profound hypotension from a widespread sympathetic block. You must place the tip of the catheter at the dermatomal level corresponding to the middle of the incision. That way, you can use a low concentration of drug to target just the sensory nerves you need to, sparing everything else.
And what about outside the spine? Peripheral nerve blocks.
Essential for modern orthopedic surgery. Brachial plexus blocks for shoulder and arm surgery. femoral, sciatic, or adductor canal blocks for the leg. And the key exam point here is the evolution to using continuous catheters.
Instead of a single shot.
Right, a single shot block is great, but it wears off in 12 to 18 hours. Then you get this phenomenon of rebound pain, where the pain comes roaring back, often in the middle of the night. A continuous paraneural catheter can provide targeted, dense analgesia for days, facilitating that crucial early physiotherapy.
Let's zoom in on a specific modality that is a very common short note question. PCA, patient-controlled analgesia.
A very high-yield topic. First, you define it. It's a system that allows the patient to self-administer small doses of an analgesic, usually an opioid, within prescribed safety limits. It puts the patient in control.
And for a Viva question, what are the key components, the settings we need to program into the pump?
You need to list the three main variables. First is the bolus dose. That's the amount of drug the patient gets every time they press the button. For example, 1 milligram of morphine.
Okay, bolus dose. What's next?
The lockout interval. This is the most important safety feature. It's a period of time, usually 5 to 10 minutes, after a successful bolus, during which the pump will not deliver another dose no matter how many times the patient presses the button.
And why is that so important?
It allows the first dose time to circulate, cross the blood-brain barrier, and reach its peak effect before the patient can take another one. This prevents stacking doses and causing an overdose.
And the third variable?
The background infusion, or basal rate. Now be very careful here. Both Miller and Stolting are quite clear that you should avoid using a background infusion in opioid-naive patients. It doesn't add much to analgesia, but it significantly increases the risk of respiratory depression, especially overnight when the patient is asleep.
So you'd save the background infusion for whom?
For an opioid-tolerant patient, someone who is already on opioids at home, they have a baseline requirement that needs to be met.
What's the main advantage of PCA over, say, a nurse giving IM injections every 4 hours?
It maintains a steady state. If you look at a graph of plasma drug concentration, IM injections give you these wild peaks and troughs. The patient is either in pain or oversedated. PCA allows the patient to make tiny adjustments to keep their plasma level right in that narrow therapeutic window, above the minimum effective analgesic concentration, or MEAC.
And what's the biggest danger? The one thing we have to warn everyone about?
PCA by proxy, a critical safety issue. This is when a well-meaning family member sees the patient asleep and thinks, oh, I'll press the button for them so they don't wake up in pain.
Which bypasses the whole safety mechanism.
Completely. The safety of PCA relies on a simple feedback loop. If a patient is too sedated, they're physically unable to press the button. PCA by proxy breaks that loop and is a well-documented cause of respiratory arrest and death.
Okay, we've covered the drugs and the high-tech equipment. What about the non-pharmacological methods? Do we need to mention them?
Absolutely. Do not skip this section. It shows you're a holistic doctor who understands the biopsychosocial model of pain.
So what do we include?
You can divide it into psychological and physical methods. Psychological support is huge. Simple reassurance, managing anxiety, providing information. Preoperative education about what to expect is a powerful analgesic in itself.
And physical methods.
Things like 10-NS transcutaneous electrical nerve stimulation.
Yep.
Acupuncture, simple heat or cold packs, and don't forget the most basic one of all, immobilization. Putting a splint on a fractured arm is probably the single best analgesic you can offer in that moment.
Let's talk about the big picture, the system of care. Postoperative pain management isn't just about one doctor writing an order. You have to mention the Acute Pain Service, or APS.
Yes. An examiner's favorite question is often, describe the role of the Acute Pain Service.
And it's not just a team that tops up epidurals.
No, it's an organizational structure. Its key functions are safety, education, and implementation of best practice. The APS provides 247 expert cover to manage the complex techniques, like epidurals and PCAs. They educate the ward nurses and the junior doctors. They write the protocols and guidelines.
And does it actually work? Does it improve outcomes?
The evidence, as cited in Miller, is clear that a well-run APS improves patient safety and patient satisfaction. It ensures that pain management is seen as a priority for the entire institution, not just an afterthought.
We have to cover complications. We touched on opioid-related respiratory depression.
Yes, and the chem exam point there is that the fear of respiratory depression is often a bigger problem than the reality, and it frequently leads to undertreatment of pain or oligoanalgesia.
But we should also mention the specific complications of our regional techniques.
Yes. For neuraxial techniques, you must mention epidural hematoma. It's rare, but it's a catastrophe.
And this connects to anticoagulation.
It's all about the timing. You have to mention the ASRA guidelines, the American Society of Regional Anesthesia. You cannot just pull an epidural catheter out whenever you feel like it if the patient has just had a dose of low molecular weight heparin. That is how you cause a hematoma, which can lead to permanent paralysis.
And there's one last complication that connects everything back to the beginning, CPSP.
Chronic post-surgical pain. It's the ultimate failure of acute pain management. The key risk factors are the severity of the acute pain, any nerve damage that happened during the surgery, and the presence of significant pain before the surgery. And the take-home message for your exam is this. The best way to prevent chronic pain is to aggressively and effectively treat acute pain.
Okay, let's move into the really nuanced area of special populations. The one-size-fits-all model clearly doesn't work. Let's start with children, pediatrics.
The biggest challenge here is assessment. You can't ask a 2-year-old for an NRS score, so you must mention the validated observational scales like FLACC, which stands for face, legs, activity, cry, and consolability. Or for neonates, the CRIAS score.
And what about their physiology?
You have to remember that neonates and infants have immature liver function, so their drug metabolism is different and often slower. But, and this is a vital historical point, they absolutely feel pain. The old, terrible myth that babies don't feel pain is dead and buried. They require and deserve effective, often multimodal pain relief.
Okay, what about the other end of the age spectrum? The elderly.
The mantra here is start low and go slow. They have decreased renal and hepatic clearance. They have a smaller volume of distribution. They are far more sensitive to the sedative and respiratory depressant effects of opioids.
And they're at a huge risk of delirium.
A huge risk. And it's a double-edged sword. Uncontrolled pain is a major cause of postoperative delirium, but so are excessive opioids and other sedating drugs. It's an incredibly delicate balancing act. Regional anesthesia is often a fantastic option for the elderly, precisely because it minimizes the systemic drug load.
What about the opioid-tolerant patient, the person coming in for surgery who is already on high-dose chronic opioids?
A very challenging clinical scenario. First, in your answer, you need to distinguish tolerance from addiction. Tolerance is a physiological adaptation where you need more drug to get the same effect. It's not the same as the psychological compulsion of addiction.
So what's the management principle?
The cardinal rule is you must continue their baseline home opioid requirement. If they take 80 milligrams of oxycodone a day at home, they get that 80 milligram as a baseline, plus whatever they need for their new acute surgical pain. If you stop their baseline, you'll precipitate withdrawal, and their pain will be completely uncontrollable.
We have covered so much ground. Let's consolidate this with some common Viva traps. You mentioned the one about relying on vital signs. What's another one?
Confusing the terminology. An examiner will nail you on this. Don't confuse addiction, physical dependence, and tolerance. They are 3 different things. A cancer patient on chronic morphine is physically dependent and tolerant. They are not necessarily addicted.
What's another common mistake?
When asked, how would you manage this patient's postoperative pain? The student immediately blurts out, I'd give them IV morphine.
Wrong first step.
Completely wrong. The answer must always begin, I would institute a multimodal analgesic regimen starting with. You always start with the principle, the strategy, before you name a specific drug.
That's great advice. Now, for the written paper, presentation is key. Are there any diagrams we should draw?
Yes, 2 are very effective. First, draw the multimodal analgesia pyramid. A simple triangle with a wide base of paracetamol and NSAIDs, a middle tier of weak opioids and adjuvants, and a narrow peak with strong opioids and regional techniques.
I'm the second one.
The PCA schematic. It's a simple graph, time on the x-axis, plasma drug concentration on the y-axis. Draw 2 horizontal lines for the therapeutic window, then show the wild up and down sawtooth pattern of IM injections constantly going above and below the window, and then draw a nice, smooth, steady line for PCA staying right inside that window. It illustrates the concept perfectly in one image.
That brings us to the summary. Let's wrap all of this into a concise package that our listener can take into the exam hall.
Okay, here is your high-yield bullet point recap, your elevator pitch for the answer.
Acute pain is a multi-system stressor that increases morbidity and mortality.
Assessment must be routine, regular, and based on patient self-report.
Multimodal analgesia is the absolute standard of care.
Regional techniques offer superior analgesia and blunt the stress response for major surgery.
You must individualize care for special populations.
The ultimate goal is not just comfort, but to facilitate functional recovery and prevent the transition to chronic pain.
And if you had to write the final, powerful conclusion paragraph of that 20-mark essay, what would it say?
It would say something like this. In conclusion, effective acute pain management is not a luxury, but a critical component of modern perioperative medicine. A systematic, multimodal, and individualized approach reduces major cardiovascular and respiratory complications, shortens hospital stay, improves patient satisfaction, and plays a vital role in preventing the debilitating sequelae of chronic post-surgical pain. And then, for yourself, always remember.
Treat the patient, not the monitor.
Exactly.
I love that. To all the MD students out there, especially those getting ready for the Gujarat University exams, good luck. You have the knowledge. This is how you structure it for success.
Stay calm, think multimodally, and you will do great.
Thanks for listening to this deep dive. We'll see you next time.